Okay, folks, we'll get started with our Viterbi Digital Technologies for COVID-19 webinar. Today, we are pleased to have with us Professor Cyrus Shahabi for our first talk of today. And he will be talking about his work on a risk evaluation platform. Professor Shahabi is the chair of our computer science department at Viterbi and is an expert on big data analytics, data management systems, and has been a co-founder of two USC spinoffs, Geosymbol Technologies and Taligo, both of which were acquired. He's authored 2 books, more than 300 research papers in databases, GIS, multimedia. Is an inventor on more than 12 patents and a rich number of best paper awards from many top venues in this space. So Cyrus, without much further ado, I hand over the floor to you.
Thank you, Bhaskar, and thank you very much for having me here today. So what I'm going to talk about today, I guess everybody heard about this term contact tracing. So I'm trying to a little bit cover that and then also say what we can do beyond just contact tracing. So to start with, so that we are all basically on the same page, let's define some terms. And these are probably some of you already familiar, but just to be clear, we have this concept of incubation period for a disease, which is basically the time between the time that somebody gets infected and shows symptoms. And for COVID-19, they've done studies based on the data collected from Wuhan. And this is basically an average of 5 days. And then there's this generation time, which is the time between when you get infected and you can start infecting somebody else. And it's usually difficult to calculate this because basically you don't know what time exactly you're infected and what time this other person is infected. So usually what they do is that they define this between the onset of symptom of the source and the onset of symptoms of the recipient. But as we know, that's not going to be accurate specifically for the case of COVID-19. So actually in this paper that I'm citing, they looked at real data. They actually looked at 40 cases of source recipient pairs. And these pairs were basically selected because they know they have a high confidence that they know exactly when they got infected. And based on that, they calculated this average and standard deviation. Now, in case of COVID-19, as everybody knows now, the incubation period for a specific person can potentially be longer than the generation time. So the person can basically be infected and can transmit the disease, but show no symptom. So this is called pre-symptomatic. Now, contact tracing is the process that basically traditionally you go and interview a confirmed case, somebody who usually is showing symptoms. That's why they get tested, for example, and you identify them as a confirmed case. And then what you do is that you interview the person and try to go back in time and identify who this person was in contact with, at what locations, and for how long, and so on. So these are the question and answers, kind of like a detective work that's been done by human contact tracers. And the question is how long back you want to go for COVID-19. There's so many different ideas. Sometime between 5 to 14 days you want to go back, for example, and check this. Now, traditional contact tracing been used usually to stop a pandemic. So at the beginning, you try to do this to basically stop the spread. Today for COVID-19, we are looking at contact tracing as a solution actually for going back to normal. And the difference is that suddenly you want to do contact tracing at a very large scale because a lot of people already have the disease. And then when they go back and you start basically your normal life, there are going to be a lot of contacts and you want to be able to do this contact tracing at scale. So the challenges with traditional contact tracing, one is actually a known challenge already, and that's the issue that usually patients don't remember the places they've been to and the people who are in contact with. So that's basically the issue of patient recall. But in particular, now we also have these two other new challenges for traditional contact tracing: the scale up, as I mentioned, and then latency. Latency is actually interesting. If you look at this graph that I'm actually taking from this second reference here, what it shows is that if you look at the number of successes in isolating cases, these are the people that basically you identified as a confirmed case. And note that this by itself is challenging because a lot of people are confirmed cases, but they don't show symptoms. So you haven't tested them, for example. And then from these, also you want to look at the percentage of the contacts of these guys that you actually got in touch. I basically told them that they potentially are infected, so they should be quarantined. There is a kind of a green area here, which this is the reproduction rate of the spread, and actually 0 is or negative is good. Basically means that you're stopping. And you see, even if you can identify like 30 or 40% of people, which is kind of the number that they are symptomatic, because there are a lot of them that are not symptomatic. If you can very quickly, with no delay, identify like 80% of their contact, you can stay in this green zone. So that's really emphasize this no delay and the latency, that how quickly you should contact people. So because of these challenges, the traditional contact tracing that you just have human might not necessarily work. So one solution that we all heard of is basically this concept of digital contact tracing, to use your mobile phones, for example, to address these challenges. Thanks to Bhaskar's group, and I'm sure this is being updated, but we look at various apps that are already out there for contact tracing, and there are a lot of them. I mean, currently, I think they're in the order of hundreds. And many of them actually being used at some level, and many of them are actually just app at the development or even pre-development stages. So there are a lot of interest in this area, as I explained in the previous slide, because of the need for it. The most popular one that probably you heard of is this approach by Google and Apple. And the way this approach works is, putting it very simply, if you have two people who are close enough to each other to potentially transmit the disease, their phones are also close enough so that they can transfer some sort of a unique identifier, let's say call it a key, using their Bluetooth, right? Now, if one of these folks later on gets sick and announces somehow, either directly or through some health official, that is a confirmed case, then you will release that person's keys for the past, let's say, 14 days. And then in some model, centralized model, or in some sort of a distributed model, you can check and say, oh, I mean, not you as a person, but your app can check and say, okay, I had these keys in the past 5 days, so I was in contact with this confirmed case. So that's basically the approach of Google Apple. And mainly this is done to respect privacy. Now, there are some limitations to this approach. One is that it wouldn't detect, these are like practical limitations. It wouldn't detect fomites transmission. This is transmissions through objects or materials that are likely to carry infection, such as clothes and furniture and so on. Because the person with the Bluetooth already left, and with the phone already left, so you cannot detect that. It cannot detect indirect transmission. Indirect transmission is a case that you have Alice transmit to Bob, and then Bob gets sick, and then you know that Bob is sick, but what you can, Bob also contact David, so you know Alice is sick, and you can inform Bob, but you cannot inform David. And informing David is important because that's really the case of the being pre-symptomatic. So after 3 days, Bob potentially can become infected and can transmit the disease. Potentially informing David and have him self-isolate or something can be very useful. The other kind of problem with this approach, not problem, but limitation, I would say, is that it can potentially generate a lot of high false positives because people can be close enough for their Bluetooth to exchange keys, but not close enough to transmit this disease, or vice versa. People can actually be far from each other, but within a long duration in a room, and still the disease gets transmitted. So these are like practical aspects, but I think by design, because the approach is going too far to the privacy preserving realm, it become by design it become an end-to-end approach. Basically, there is no human in the loop, in the sense that the only way to connect to people is to the app telling them whether they are in contact or not, and the health officials, the maximum participation from their side is just to say, okay, this person is a confirmed case, and that's it. They are not really participating in the real contact tracing, and that's I think is important, because you want to know if this person, for example, was wearing mask, what type of location they were in, and so on. So it's a very good start, but I think there are more data that needs to be connected. So if you think of the traditional contact tracing, they collect location data, duration, who's wearing mask, and all sorts of data in order to be for this to be effective. So what we are basically suggesting is to go beyond just contact tracing. I know there's our privacy issues, and I'm going to talk about this later. But basically, the idea we have is to have some sort of an opt-in voluntarily app that collects more data. For example, it collects the location traces, the durations, and so on. And then instead of this 0-1 situation where you either in contact or not in contact, you provide some sort of a risk score. And this risk score is not a genetic or biological risk. It's basically based on your mobility pattern, based on your mobility behavior, the location that you've been to, the people that you're in contact with. We calculate some sort of a risk score. And the other interesting aspect of what we're basically proposing is to kind of separate the app, which is a data collection tool, from the actual process of contact tracing. I mean, the contact tracing itself can happen by human contact tracer, but we provide dashboards and tools for them that utilizes the data that collected by the app in order to do a more efficient contact tracing. And of course, the privacy preserve is important, but one of the other advantages is that you can also allocate risk scores to locations based on the data that you're collecting, and you can basically use that data to also inform spread models. So that's our idea. Let me show that in a kind of a visual form. So the idea here is that you have the app here. The app collects location and co-location. Co-location comes from Bluetooth proximity. Location, of course, can come from GPS, Wi-Fi strength, and so on. And then you do potentially you can store this in a secure place, and then you can support spatiotemporal analysis on top of this data, which would I'll tell you more about these boxes later. But basically, that's what the health practitioner dashboard can be used for the actual contact tracing. You can basically separate the confirmed cases from the rest of the data, and that can be something that is secure and private. And you have the confirmed cases, but you can feed that into some sort of a risk analysis that take these information as well as the location information, and in a privacy preserving manner can do the analytics, which would generate these risk scores that can inform the policies like spread models and so on, as well as potentially this risk score can go back and be fed back to the user, basically, so the user can see the risk score. And the idea here is that I'll tell you about the risk score a little bit later, but let me tell you where we are actually with each box. So, sorry, the spatiotemporal analysis part I'm working with Peter, who's going to talk later. We already have an app that can collect the data and it can collect certain symptoms. We also have received a funding from NSF to look at these spatiotemporal analysis of the data collected by the app. And we show basically that if you have these traces, you can calculate both deformity and indirect transmissions from the collected data. And it's kind of, the idea is that you have a confirmed case, and this is basically a trace, various locations. You can immediately find the co-locations, so you can say, you can inform direct transmission, but also you can identify indirect transmission when, assuming this is enough time gap, like 3 days, for example, to inform the indirect transmission. And you can also tag the formative transmission, where the person who was infected actually was there at time T3, but the other person came there later at time T4. And you can still say that there's still some risk associated because this person is potentially touching things that the other person left. That the risk analysis part basically is a typical machine learning data mining task that you're all familiar with, which basically takes all this information, various risks because of the contacted individual, locations and so on, duration, and put all that into some sort of a machine learning approach, and then generate these risk scores. And we've done some work related to this in the past that can be useful. One, for example, is that study showed basically that the chance of transmission between people that they know each other is higher than the people that they don't know each other if they are at the same location at the same time. And there are ways to actually mine the previous data in order to infer these potential social relationship in physical worlds. And these are not necessarily that you're relative of each other. It might be like that you're classmate and you end up in the same class all the time. And if this happens over time, then there's a higher chance of transmission. Moving on, basically this is the spread analysis box. The idea here is that if you have this high resolution visit data, and a lot of companies collect this data, including Google and Apple, then you can generate these simulation where you basically randomly make some of these guys infected, and you know exactly where these guys went, and you have their location history. And then you also have these SIR or SEIR models that you can basically know how the virus spreads. And then using all that information, you can look back and say, okay, if I start with, like, say, one person infected and they go through 2 weeks of mobility per the data you have, how many of them end up to be infected at the end? And this data set can potentially be used for training your risk analysis model. So you don't really need to have real data to train it. And then using that risk analysis model, we can start predicting these risk scores, both for locations and people. And then based on these, you can do some sort of intervention strategy. And this can be very simple. It can be if somebody's risk is above 0.8, just stop moving, right? Or if a location risk is above 0.9, then stop admitting new people. And by implementing these intervention strategies, you can rerun this with these new kind of interventions and see whether that would reduce, for example, the number of infected folks. So this kind of a cycle can help you, and the more real data you have, the better your predictions going to be, and the better your spread kind of predictions forecasting can be as well. Another box that I talked about was this health practitioner dashboard. This is basically where the actual contact tracing happens. So health practitioner can actually look at people's traces and automatically see who was in contact with who, and then ask more questions specifically if they want to, or just let the system automatically identify things and they just click and say confirm, and so on. The same way that the policy dashboard can be used on top of the same collected data to see how, if you have a hotspot, if there are places that are high risk. I'm sure by now everybody's like freaked out that, okay, this is a lot of data with privacy invasion and so on. So of course, all this can be implemented with all these considerations. These are taken from these two websites, that it's transparent, it's voluntarily, it's secure, and so on. And I can tell you a little bit about some of these actually. So for example, for the NSF project, what we were proposing is that these location traces can be stored locally on the app. It doesn't need to be shared. And user can have full control on whether how frequently the location can be shared, the precisions, and the, even redacting some locations. And then one interesting idea we're investigating now is that you have this two-stage iterative approach where basically we tell you, hey, if you share the current location information that you're sharing is very good. However, if you identify this location further, if you tell us exactly what that location was, we can potentially save 4 more people or 10 more people. And I think by this iteration, people are more, and we did some actually surveys already, and it shows that people are more willing to share more information if they know that they're helping other people. And that can be a process in place. Interestingly, for the contact tracing, the locations that are sensitive are less interesting because those are, for example, your home, and we know that you're probably going to tell the people at your home that you're sick, right? So it's less of an issue there as opposed to when you're in a classroom and there are all your classmates around you that many of them you don't know. That's a more public location that you might be willing to share that information. It's less private, but at the same time more important to our risk analysis. So interestingly here, there's less of an issue of privacy when it comes to public location, but more interesting data actually when you're in public. There are a lot of other detailed approaches that we can use, which is basically building on what I've mentioned. So we can basically, if you're very concerned about privacy, we can do the entire contact tracing in an encrypted space. Of course, the contact tracer would eventually, the human contact tracers would know, but nobody else would know anything about where the locations were. This is another NSF grant that we have to do this in a this whole queries in a contact trace. And this paper actually explains how you can do contact tracing queries in a completely encrypted space. Or this idea of the accuracy of the location, you can basically do it more mathematically by adding noise to the location that you share. And then there are some other privacy preserving approaches for the risk analysis. That was my last slide. Maybe I just allow for some questions.
Great. We have a few questions, Cyrus. So one of them is, don't you need 60% of the population to use contact tracing apps to be effective?
So this 60% is based on the concept of if you only collect contacts, right? I mean, if you only go with this Bluetooth contact idea and you want to do the whole thing fully automatically. What I'm explaining is basically, even if one person collects its traces and then that person is a confirmed case, and that person goes to the USC Student Health and the contact tracer look at that and say, oh, this person went through these classes, so let's inform the people in the classes that, hey, this guy was a confirmed case. That one case, one data collected, already showing some usefulness. Yes, if we do collect only these pairwise proximity, we need to have certain amount of people to use it because it's an end-to-end fully automatic, but we are not proposing that. We're actually saying that we just provide tools for human contact tracers to do things better. So even 10 of them would be useful.
We have another question saying, how are the risk scores going to be translated or interpreted by the users of the app? Who are the main users of the app?
So that's a very good question, actually. So that is a study we need to do to basically, because it's also, I mean, this is a risky business, right? I mean, you provide risk scores to people and then they say, oh, my risk score was low, but I did get the virus. But so you want to make sure that you have enough messaging that this is just a heuristic for some basic information for you. It's not a medical kind of diagnosis. The risk score actually depends a lot on your biology, on your age, on the demographic information, which we don't have. So that's the messaging. But the potential users of the app can be a community, like for example at USC can be USC staff, faculty, and students, for example.
We have a question that says, there's sort of a behavioral economics aspect to this. What are the most effective incentives for participation for different segments of citizens?
Yeah, so that's actually what I was trying to allude to. So we started working actually with Microsoft Research. We submitted a proposal just a week ago, and we're going to hear by mid-June. And the whole idea, and that's where we started doing the surveys, the whole idea is that, which is kind of interesting, this risk model that I was talking about, if you're familiar with the federated learning, this risk model, which is a machine learning model, can run centrally, but the version of it can run locally on your phone. So on your phone, you just have a model that is already trained. Now, this model would basically calculate your risk score and other people's risk score, for example, based on the actual data, because the data that you have on the phone is the most accurate data. And then it can also calculate it, assuming that you share a subset of your information, right? And then see what's the difference, right? And then it can tell you, it can immediately give you a feedback and say, hey, if you give me more data, I can do this much better, right? And again, the study that we did is that if you say that, okay, we want to collect your data and share it with the researchers to do contact tracing research, not that exciting. But if you say, hey, if you give me the data, that would help 10 people to know that they were infected, or their risk is high, or this location can be decontaminated, then people are more willing to share their data.
Just along the same lines, is the risk profile of a user part of the equation in terms of whether they're young, male, high BMI, high population density, where they're living or spending time?
So this is this privacy data trade-off, right? I mean, of course, if you provide that information, the more data you have, the better. But currently, we are only looking at this risk based on the mobility pattern, not based on any sort of demographic or community or biology or genetics.
There's a question if all the data would be on USC servers, and related to that, how long would it be stored before being deleted?
Right. So again, we are not at that level. We are not operational, of course. So, but the hope, as I mentioned in some of these considerations, is basically, yes, the data should be only temporary. It should have an expiration. It should be secure. It should be stored locally on, for example, in the case of USC, on campus. And we want to minimize the least amount of information you can collect.
Great. I think just a comment as well that perhaps this could also be used to help persuade skeptics about their actual risks.
Right.
Excellent. I think with that, we'd like to thank Professor Shahabi for his presentation, for taking some questions. We're going to move to our second speaker of today, who is Professor Peter Kuhn. Professor Peter Kuhn is a professor of biological sciences in the USC Dornsife School, and he also holds joint appointments in the Keck School of Medicine as well as the Viterbi School. And he has been the founding director of the Convergent Science Institute in Cancer, and has published more than 200 papers, many patents, and really will be giving us kind of some of the biological aspects of it, but also thinking about restart beyond the present. So Peter, take it away.
Unmute. There we go. Thank you, Bhaskar. So Cyrus and I and a number of other faculty, of course, never really intended to be working on a global pandemic. But we realized that the thought processes that we had in place in our other research areas are actually quite applicable here. One brief comment on one of the questions, or on Cyrus's presentation, is also keep in mind that the human tracers that Cyrus pointed out would actually be part of the healthcare provider, right? So there's this flip of de-identified data within the data collection world, right? But then only when you go to a healthcare provider and you say, I am infected, that is when the healthcare provider starts working the way through their primary and secondary contacts. And part of the challenge in all of this is, of course, that we have never really had this case of public health concerns. And so that's, again, what makes a lot of this quite difficult. So what I wanted to do was also because of this audience, it's a beautiful opportunity to describe a little bit of what might be happening next, and how technology will actually play a huge role in whether or not we are successful at managing our way through this pandemic. And so again, I will be using terms, both the virus itself, so the infection, as SARS-CoV-2, and then the disease COVID-19. So there's an interesting observation here, actually, and I want to touch on that a little bit, because some of the questions that were asked of Cyrus also had to do with our emotions, and even that last question of convincing the skeptics of their actual risk, right? So it's an interesting bit. During the beginning of the outbreak, when we still had sort of single and double-digit infections in the US, my family, we marked the numbers every night. Every night at 6, we would mark the number on a whiteboard in the house, right? And at some point, the numbers just get so big, right? You somehow go numb, and you look at the map, and you're like, oh wow, yeah, the map seems to be getting worse, but I'm having a hard time actually wrapping my head around it. But if we put this into perspective, right, the 95,000 deaths in the United States now, right? This is more than Vietnam, the Americans who died in the Vietnam War, Pearl Harbor, and 9/11 together. But emotionally, this whole skeptic comment that was just made, right? Emotionally, we are not making the same connection that we did with any one of those 3 events. For those of us who actually lived through any one of them, like 9/11, where actually the entire country came together and really mourned through these sets of events, and together tried to figure out how do we respond to these events. And interestingly enough, that's actually missing in this case for a number of different reasons. And technology is one of those reasons. And so I think there's actually a greater responsibility on us now to figure out how technology can actually help us to get out of this strange mode. So again, as I said, my entire research career was really focused on inventing the future of cancer care for patients. And the global SARS pandemic was not really part of the equation. I will, however, touch on the future of care a little bit. And so Epic Sciences is a company that we spun out when I was still at Scripps that is now providing cancer care diagnostics to patients, and Cancera is a spin out of USC that is really is looking at that human health performance, which includes a lot of the mobility work that we have been doing together with Cyrus. And of course, that led in many ways intellectually to what we are doing now with the geospatial mapping. And then there is a lot of machine learning, math model building that we're doing in this cancer space as well. Sorry, this last part was supposed to show up only at the end, of course, of the slide. But what is it that we need right now, right? So we need vaccines, and I bolded the S because it is more likely than not that we need multiple vaccines, because likely there will be multiple strains of the virus that will be a threat around the world. We need drugs, and there's 2 types of drugs. There are antivirals, so drugs that are against SARS coronavirus 2, but we also need drugs that are anti-COVID-19 as a multi-organ disease. And it's that latter part that's actually making progress faster for a number of reasons. This last piece, it's really important for us to wrap our head around, because it relates to a lot of what Cyrus was just talking about. And that is that lots of people are asymptomatic, lots of people are mild and moderately symptomatic, right? But a small fraction of them will actually, over that 5 days to 10 to 15 to 20-day time period, a small fraction of them will deteriorate and become severe and critical. And then once you're in the critical space, once you're in the ICU, you have a sort of 30 to 50% chance of death. What we really need to do is, and those who progress through make up for over half of the deaths in the end, right? So that means that if we can keep people in this mild and moderate symptomatic space, right, we could make a massive difference in terms of the progression, and with that, in terms of death. And again, this is this strange interplay of technology, biology, and healthcare and society that somehow we have to figure out how to identify these patients early enough, and what are the best treatment modalities to actually help these patients. So the other part that I always want to come back to when we talk about concepts of restart or reopening, there's actually a basic set of numbers that we need to wrap our head around, right? And that is that in February, we missed the opportunity of keeping this at the containment level. So containment as in there is a local, like the SARS coronavirus in 2003, because of a number of different reasons, including a global effort to contain the outbreak clusters right in the beginning. It never escaped from this framework of containment. We never had to go to mitigation. We lost that in February, so we are now in mitigation, and we have to figure out how do we push it back so we can go to containment. And we have to think about what are the numbers behind that would actually support the notion of mitigation, getting out of mitigation, going back to containment. And this is where testing is so absolutely critical. But again, what we haven't done yet, and which I think is an opportunity for us to really do, is that who to test and when, that's really should just be a math problem, right? That's a geospatial mapping problem. It's a real-time data problem. And in an ideal world, right, there would be an algorithmic approach about when a nurse shows up at somebody's home and says, it's your time to get tested today. And the same thing when it comes to people coming back to the USC campus. And then with that is this mapping of incidences and the incidence rates in an overlap with the mobility patterns. And I'm specifically not calling this contact tracing, right? Because the mobility patterns are important for everybody. And they don't have to really say anything about contacts at all. Those are just mobility patterns. If the individual, once diagnosed, takes this back to their healthcare provider, and the healthcare provider is now treating that patient and is working through this aspect of actual tracing back contacts where the mobility data will be that crutch because we are terrible at recall, then of course it's a different story, but that sits on the healthcare side. And then of course, this is this tracing to contain clusters of outbreaks, right? But we're still in mitigation. We're not in containment yet, right? So we can't even really talk yet about clusters. So this is the immediate need, right? But so that's like this morning, right? But what we need also today, right, are three very, very basic things, right? We need all of healthcare to reboot and to reboot fast, because we don't want people to die of other diseases. It is a major, major concern. The second piece is the food supply chain needs to be stabilized very, very fast so that nobody goes hungry. And again, it's something that we have unfortunately missed in this country. We have done a really poor job at maintaining the food supply chain in such a way that all food that gets produced can actually reach people in the end. And the third part, which I think is critical, is social fabric innovation, so that mental illness does not become another pandemic. And I'm saying here social fabric innovation because it is not the same as saying we have to open up our bars and our gyms so that people can interact again, so they don't go nuts. I think that's not the right way of thinking about it. I think there's a better way to think about it, and that really has to do with social fabric innovation. And again, technology should play a big part of that, because eventually we want to go towards an experience that's beyond just Zoom. So then the healthcare restart, right? I think for us on the technology side, we need to wrap our head around what this future might look like, right? So we are looking right now at the models and the model predictions that we currently have in front of us are of course assuming that there is no real change in the viral behavior. But if we are thinking through what's going to happen over the next 3, 6, 12, 18, and 36 months, right? There's lots of schools that now say, oh, let's start early in August or maybe even in July, because we likely will have to shut down at Thanksgiving again, right? Once we get into this winter time period. So, but nobody really knows what's exactly going to happen. So there's amongst many different possibilities, right? But in that core space, right, there are 3 possibilities. And that is that the virus has already spread so far through the population that it now has a level of prevalence that it reaches robustness. Okay, and with that, it will just sort of like cycle on forever, and we have to deal with it until we have effective vaccines in place. A second possibility is, of course, which was not an unreasonable assumption and still is a possibility, is that in an evolutionary game, a high lethality is actually not desirable because the host dies fast. Okay, so if the patient dies fast, that's actually evolutionarily not a desirable outcome for the virus. The virus would much rather, evolutionarily, infect lots more people. But that hasn't really taken place yet, in part of because of what Cyrus described in terms of this long lead-in time. Okay, there is of course this other possibility 2A, but that's a weird one. I think that's a bit out there. A third possibility is this second wave concept, right? And that is that this virus is in fact a damp, cold, thriving virus that will come back in the fall and in the winter with a vengeance. And there is discussion around, so the Lead Institute in Germany, the Viral Institute in Germany, is sort of like provides the same kind of guidance as NIAID does in the US. And a number of infectious disease groups are asking this question of, why do we have these outbreaks in the meat processing plants right now? Because there are other industrial environments that have, also tough working conditions, but the outbreaks don't seem to be as bad. Does it have anything to do with the cold temperature and the humidity in those environments? Again, it's the type of science that has to be worked through very carefully and very quickly to start understanding what might happen when we get into the wintertime. Now, mind you, in the wintertime, even if it stays the way it is today, it's going to get very complicated, because if you walk around town today or whatever, or wherever you are, even if 50 feet away somebody sneezes, right, you'd be like, oops. Right now, again, as we go into the season of respiratory illnesses, think of the classes that you're teaching, right? We always have a double-digit percentage of students who either call in sick or have some sort of sniffles. And again, we have to keep in mind of like, how are we going to manage that as we go into that time period? There we go. So now, there is a bigger problem in all of this, right? And that is that as we're trying to restart healthcare, is the fact that COVID-19 as a disease, no matter what the virus does, is actually here to stay. Okay, we have already 500 million have already been infected, and of course, remember that herd immunity would be reached at 5 billion people. So that I can't even wrap my head around that number. But with that many people having been infected already, and remember, when we talk about asymptomatic, mild, moderate symptomatic, we really, for the most part, just talk about the immediate respiratory illness symptoms, right? We don't really talk at the same time about all of the other illnesses that viral infection actually causes. And that's something really important because, in fact, we don't really know what the long-term implications are, right? So the Kawasaki disease is an interesting example here, right? Because again, the assumption is that this viral infection, because as it drops into the lungs and causes severe lung tissue damage, the immune system responds and seems to be overreacting at times. And interestingly enough, that can actually happen even with a level of damage to the lungs that might actually not even be symptomatic from a respiratory illness perspective. So, and we don't know what the long-term implications of these autoimmune inflammatory diseases are. What if that goes away and what doesn't? The lung tissue damage, as I just mentioned, of course, then results in lung scarring. What is that going to look like? And then the observations around all of the cardiovascular diseases, meaning the blood clotting risks and heart failure risks, during the immediate acute setting of the disease itself, but also the long-term setting. And then, of course, the nervous system. And now keep in mind that a lot of these are unknown at this point. It's unknown biology, it's unknown disease effects, unknown length. And we have a lot of patients that are affected by this, right? I mean, 1.5 million right now in the US, and pick your number of where you think we're going to be once the infection itself starts tapering off. So many of the symptoms will subside, but it is really unclear what the long-term and chronic conditions may look like. I want to touch briefly, presumably, and I don't know, many of you might have seen the reports around the Kawasaki disease in young children. And Kawasaki disease, again, it's an interesting case, right? Because nobody really knew what the causative agent is. So if we now assume that it is actually the coronavirus, right, the implication is actually quite significant because a lot of these kids actually never had real symptoms, right? And again, the symptoms are really with regards to the respiratory illness. But this means that a SARS coronavirus 2 infection can actually cause really, really severe disease. So Kawasaki has, again, a long-term risk of typically an acquired heart disease. But the viral infection can, in fact, cause these other diseases without ever causing respiratory illnesses. So we will be in a brand new world of trying to map disease patterns. And for every disease from here on forward, we will ask the question of, well, for this patient, is this in the context of a prior SARS-CoV-2 infection? And this also relates to this other question that was asked of, will a risk score actually take the comorbidities into consideration? We need to start asking that question the other way around. And that is, for every cancer drug, for example, that will go through clinical trials as we go forward, we will ask the question of, are we tracking the SARS-CoV-2 infections for these patients, either during that treatment or anytime prior to that? And again, it's an important piece that is it's a brand new world. I want to finish up with just a slide on this other observation of what has happened, right? Over the past few months, we have seen a massive shift to telemedicine. And what is really interesting about all of this is that people have talked about telemedicine for the past, 10, 20 years, for a very long time, okay? There was always questions around, oh, it cannot get reimbursed, oh, it's not HIPAA compliant, et cetera, et cetera. And all of this got overturned in the blink of an eye. So now, any kind of platform, many different platforms are being used for this patient-physician interaction. And of course, it is also reimbursed just like a in-hospital visit, and even a telephone call, which again, in the past was never really reimbursed, is now reimbursed just like an in-hospital visit, which is very, very interesting. But of course, there's a big challenge with that, and that is that what we are missing now is the routine vitals, because they are not typically being taken at home. And of course, more severe than that are the standard diagnostic measurements. So again, for cancer patients, for example, or for people who are at risk of cancer, their routine imaging, whether that is ultrasound, MRI, PET, CT scans, they are happening at a substantially reduced frequency. They're down by more than 50%. So interventional procedures are currently restarting. right? And of course, they will have to be in the clinic, but it is quite likely that many components of telemedicine will actually persist well beyond this immediate pandemic. There are a lot of challenges that have to be overcome, and they have to be overcome with technology innovation, and they have to be overcome fast, which is what I want to focus next on, because it has to be actionable. So with that, it is really important that for all those of us who are thinking through how does computer science, engineering, technology, basic science, biological science, how does my research play a role in that future? We have to accept the fact that the future has just been compressed down radically. So I would encourage everybody really to carefully think through this. Define your clinical intent first. So what is the actual specific problem that you're trying to solve? So for example, in our world, a lot of people talk about, oh, I want to work on early cancer diagnosis. Well, that's really hard because finding a cancer at any given size is oftentimes not even all that hard. The hard part is the clinical intent, meaning I want to improve the diagnostic workup that can separate consequential from inconsequential cancer. Because then it's actually something actionable. Because I need to know whether or not the thing that I'm finding that is cancer poses a risk on my life or not. Because if all you're telling me is that there is a cancer, but you're not telling me whether that is a risk to me over the next 5 years or poses only a risk to me after I turn 100 years old, in the absence of that, it's not really actionable. So it has to be actionable. And then we have to take responsibility for our science as we go forward to really achieve better outcomes. Meaning, if acted upon, the results of my technology on that specific patient population will allow people to live longer and or better. And again, this is completely reflective also what Cyrus was showing, right? Cyrus did not say, hey, let's do mobility tracking because it's cool science. It's actually mobility tracking for better outcomes. And again, I think that's something that we all really need to keep in mind. So with that, what is that augmented medicine? And I only have 2 minutes left. So interventions like surgery will always take place in the hospital. Imaging will also always take place in the hospital. However, many of those could actually be replaced by other liquid biopsies or mobile devices. So there's an enormous amount of innovation that can take place in this space now. Taking vitals, so pulse oximetry, heart rate, weight, temperature, height, all of the stuff that you typically do when you see your physician, right? They can be done at home, but that requires substantial innovation because typically these home devices currently, they're less accurate just from a device perspective, which is what on the technology side we typically think about, but as important or as complicated and challenging is that self-measurements are prone to greater deviation and errors. And when we build technology, we really have to think about that human experience and how does that human interact with the device and how can that then produce accurate results. The doctor-patient interaction, this is my last slide. We have to reimagine that doctor-patient interaction that has not been redesigned in a meaningful way in decades. Actually, Erica Mule from the Ivy Young Academy has pointed this out over the past 4 or 5 years already. At some point, we went from home visits to clinic visits and hospital visits. COVID overnight has turned us sort of like almost like back around. It's just that we don't visit the home, it's telemedicine. But the one problem with the way we're doing this currently is that you don't know whether I'm wearing pants. Okay? You only see this little bit of me. You don't know whether I can walk. You don't know whether I have seen anybody else around me. In fact, you don't even know where I am. And it's that part that's missing from that patient-physician interaction. And with that, I will close. And back to Bhaskar.
Great, thank you, Peter. We have a few questions, and one of them, let me set up the stage a little bit because it really does start to remind me a lot of this, maybe old Indian story of blind men trying to describe an elephant, thinking it's a rope or a pillar, depending on which part of the elephant they're touching. So we've got, the engineering perspective on this, the computer science perspective, we've got the biology perspective that you presented, there's a physics perspective on the flow of all this. And one of our questions here is asking, please discuss how the social sciences, the psychology and anthropology, are contributing to the definition of the problem and the design of solutions. So what's your view on that?
Yeah, so we can really simplify it, and we have, so as those of you who have seen what we have tried to do over the past 5 years since we have come to USC, is this effort around convergent science. And it was actually Gary Michelson who, in a conversation with him, where he said, well, Peter, you need that point of convergence. Okay, find one point of convergence. And this is really simple when it comes to disease. Okay, it's the patient. If we focus on the patient, in our case, in the past, it was always the cancer patient. But if you focus on the patient, then we can all rally around that, right? We can all say, oh, how do I contribute to better outcome of that patient? And then the disciplines, because every discipline will have their own value proposition, every discipline will have their own processes, expectations, etc. Because all of the other disciplines across the board, it's not just it's social science, it's preventive medicine, it's epidemiology, it's healthcare economics, right? I don't know whether anybody from the economic side is part of this, right? All of them, but it gets so diverse and so very quickly. We lose boundary conditions in terms of what we're trying to do. And the way to, I'm a big fan of thinking of this as, hey, let's make the patient our point of convergence, and then really truly focus on better outcomes. And then we can all play together much easier.
We have another question that is asking about testing. And so is there a solution to all this that really just blanket testing of everyone, and then we get back to containment? And is that feasible at this point?
Yeah, somebody said the other day, right? I forget how many cans of Coca-Cola and Pepsi do we produce on a daily basis, right? That number is higher than any testing requirement that we have. So it's very simple. We need a mask for everybody who goes outside every day. And the idea of like, oh no, we can't do that. Well, last time I checked, we all wearing, no, it's not hard. We just have to do it. And the testing is the same thing. However, with the caveat on the testing, there has to be a math model underneath the hood. Okay, because testing everybody every day doesn't work, right? I need a spatial distribution of testing and the temporal distribution of testing, and that has to come from a model. Do I believe that we need anywhere from the Paul Romer and others have put these models forward of anywhere from 4 to, I think, 20 million tests per week? Absolutely. And is that doable? It is absolutely doable. Last time I checked, we are the US, okay? And we just have to get on with it. Innovation will drive that. We can invent our way out of this. I have zero doubt. We're underutilizing everything that we have today.
Great. So this is a question about, I guess, health data in general. So for years, proprietary client-server data systems were sold to medical care providers with designs that prohibited data sharing. Challenges to that model, such as cloud platforms, were attacked using HIPAA standards arguments, cybersecurity, but it appears this was fear-mongering and that cloud-based, interoperable, shareable electronic health records is now reality. Do you agree?
Oh, that's one of my favorite topics and questions. So for those of you who are old enough who remember Napster, okay, the music industry had the same arguments around proprietary, protected, special formats, higher quality, and all of that, okay, until somebody came up with this right mouse click and share. Now, the profound part which relates to this topic on the medical side now is that it was shared by the individual user. So I think the actual disruption has to come from the patient, from each one of us, by sharing. It is really hard to get this disruption from the healthcare side, because you don't want to disrupt healthcare because people die. That's a really bad idea. But there's a couple of legal aspects that have happened. 21st Century Cures Act, one of the last laws signed by President Obama, actually clarified that each one of us, we own all of our medical record data. And in fact, the Trump administration earlier this year actually added on to that and said it has to be easy to download your data. So there's a couple of legal processes and policy processes that had to come together. And that is why we are in a much better place today as we were before that. But keep also in mind that the old medical records that were built were only built for the purpose of billing. They were not really built for the purpose of care. Now, all of a sudden, this is migrating into actual care, right? Because we are adding algorithms into these medical record things, you know, and that's really changing that entire game.
Fantastic. I'd like to thank Peter and Cyrus as well for a very enlightening set of talks and answers to the questions. Thank you all for joining us, and we'll see you next week. We'll have another episode of this webinar with speakers to be announced. Thank you so much.
Thanks.
Bye.